Good morning, dear colleagues, ladies and gentlemen. These videos were taken 2 weeks ago in the pre-conference that the IAS and the Eurasian Harm Reduction Network had organized in Kiev in Ukraine. And during that conference, I must say, I did hear many such powerful messages as those that you've just heard. Let me start with some figures and numbers, some of which, Bertrand, you already mentioned. Injecting drug use accounts for 1/3 of all new HIV infections occurring outside sub-Saharan Africa. This, of course, doesn't mean that drug-related infections do not occur in Africa. Actually, as you mentioned, it's a growing problem in many coastal areas of West, Southern, and Eastern Africa. Globally, there's an estimated 16 million people who inject drugs, of whom, on average, 1 in 5 is infected with HIV. HIV prevalence among people who inject drugs ranges from 12% and 15% in China and the US, respectively. We just heard 17% from the director, to over 35% in the Russian Federation. And as you all know, whereas the global AIDS epidemic appears to have somehow stabilized, with the number of new infections having decreased by 25% in the last 10 years globally, and fewer AIDS-related deaths occurring because of the huge scale-up in antiretroviral treatment, one region and several countries do not actually fit the model. Of the 7 countries where UNAIDS reported on a 25% increase in HIV incidence in the last 10 years, 2001 to 2009, 5 are in the Eastern European and Central Asian region, where transmission through drug use accounts for over 60% of the cases, and where the war on drug is actively fought with little or no attention to harm reduction and public health. So it is in this context that in its report released a few weeks ago in June in London, the Global Commission called the world, national leaders, and all UN agencies to acknowledge and urgently address the causal links between the war on drugs, I would also say the war on users, and the spread of HIV/AIDS. Clearly, the AIDS epidemic in people who inject drugs and their sexual partners continues to be a serious public health emergency that the world is failing to address, despite the evidence that harm reduction strategies are highly effective in preventing HIV infection among people who inject drugs, and despite the evidence that many countries have actually succeeded in drastically reducing HIV incidence and prevalence among injectors. In no other disease, and for no more marginalized population, does such willful blindness to evidence persist. Harm reduction, by the way, is not just one or the other intervention. Harm reduction, as advocated by WHO, UNAIDS, UNODC, is a package of intervention. That package includes needle exchange programs, opioid substitution therapy, information and education, overdose prevention, and engagement of people who use drugs in decision-making, to which I would also add safe injection sites. The evidence that harm reduction is effective in reducing health harms to people who inject drugs is just comprehensive, compelling, and conclusive. And to me, despite the attempts to do so, absolutely undeniable. The epidemiological evidence is also clear. In countries that have adopted harm reduction strategies to drug use and addiction, the HIV epidemic among people who use drugs has declined, as we have seen in many countries in Western Europe, as I have seen in my country, in France. but also obviously in Australia or Canada. However, in countries and regions that have neglected harm reduction and relied on ineffective and aggressive drug law enforcement, the HIV epidemic does not decline among injectors, as we see in Thailand, as opposed to a decrease in Thailand in the infections in the general population, or growing fast and worsening and spreading to the general population, as we see in the Russian Federation. I've read a paper that provides recently a mathematical model of HIV transmission among people who use drugs in Russia, which suggests that assuming a baseline prevalence of 15%, which is probably an underestimation, coverage of opioid substitution therapy from the current 0 to, let's say, 25% of all people who inject drugs could decrease HIV incidence by between 45 and 53%. But a lesson that we've learned from the Western European and Australian experience is that to be implemented successfully, harm reduction strategies require a collective dialogue to occur first, and then a politically and socially, societally acceptable shift in policies, a dialogue and a shift that is actually the main message of the Global Commission. That's what we are calling for. And let me add that more focus on evidence-based policies and cost-effective interventions is also crucial in times of economic downturn, as we see now. We know too well that the economic slowdown will have a disproportionately negative impact on stigmatized and marginalized groups and on the poorest segments of the society, including, I believe, an inevitable increase in the use of problematic drugs and injection rates. So, ladies and gentlemen, 40 years of the so-called war on drugs and prohibition law enforcement have failed, I would say have failed abysmally in their primary goals of first eradicating drug use, and second, protecting people's health. They have failed by every conceivable metric. Trends in drug use have risen consistently. The global supply of opiates has increased by 380% in the last 25 years. Illegal drugs have become cheaper and more available. The price of heroin in Europe decreased by 75% between 1990 and 2009, while also improving in purity in a number of markets. And similar curves of decreasing prices and increasing purity have been seen for both heroin and cocaine here in the US. At the same time, as illicit drugs become more widely available, HIV/AIDS and hepatitis and other health risks associated with drug use increase dramatically. People living with HIV who inject drugs have a 2 to 6-fold increased risk of developing tuberculosis as compared to non-injectors. And the prevalence of hepatitis C in people who use drugs ranges between 30 and 90% worldwide. So let us not just speak of the twin epidemics between drug use and HIV, but rather the quartet of HIV, drug use, TB, and hepatitis. We cannot address one without addressing the other three. We also know that drug users face tremendous barriers to accessing health services. Fear of police and stigma drive users underground, away from prevention and away from treatment. And as a physician, I'm sorry to also say that stigma and discrimination are also often present within healthcare settings, leading to refusal of services or absurd requirements for being drug-free as a precondition for treatment and breaches of confidentiality. As a result, it is estimated that at most only 10 of 100 injectors in need of therapy actually access antiretroviral therapy. This remains a scandal at a time when antiretroviral coverage in low and middle income countries globally is now over 50%. The figures are embargoed until today, 18th of July, but the figure is 54% globally, an extraordinary progress based on the CD4 cell counts below 350. So while global access of ART becomes more equitable, the inequities for drug users just seem to become even more entrenched. A study published a few years ago had also shown that when HIV-positive injectors do access antiretroviral treatment, their life expectancy on treatment is up to 12 times lower than for a non-injector. So it is clear that the range of health needs of drug users on treatment is often not being met. The emphasis on drug law enforcement has created legal barriers to evidence-based HIV prevention measures, such as provision of clean syringes, needles, and methadone maintenance therapy. The result is that only 8 of every 100 injectors, 8% globally, receive OST at this time. Methadone, as you know, is still illegal in Russia, and access to it far too limited in many countries, particularly in Asia and countries of the former Soviet bloc. And I was sorry to hear again the director remind us that US Congress recently reinstated the ban on federal funding of Syrian exchange programs only 2 years after it lifted a 21-year-old ban. Everyone of us here is deeply aware of the social harms associated with drugs, but these harms are only exacerbated by prohibition law enforcement. The 50,000 homicides reported in Mexico since the war on drug cartels began is an extreme example of such devastating social harm. There's also evidence that prohibition policies are somehow tilting the markets towards more potent and risky products, often cut with contaminants, and that such policies actually contribute to high-risk behaviors, including injection in highly unhygienic environments, something I heard repeatedly in Kiev 2 weeks ago. And prohibition law enforcement has led to a true war on users and what I would call an epidemic of human rights abuse. People who use drugs who are arrested or suspected of drug offenses are subject to police harassment, police violence, abuse of power, and extortion. Incarceration for minor drug-related offenses is one of the main reasons behind the increase in prison populations globally. To make matters worse, incarceration is itself a risk factor for acquiring HIV through needle sharing or unprotected sex. HIV prevalence among the 2.4 million people currently incarcerated in US prisons and jails is estimated to be close to 10%. Around 25% of the people living with HIV in the US and 30% of those living with HCV have spent time in correctional facilities. And the disproportionate incarceration rates of African Americans, including for drug offenses, is considered as a factor in the markedly elevated rates of infections in that particular population. And let me just leave you with one more number here. At a global level, the risk of acquiring TB in prisons is on average an extraordinary 23 times higher than the level in the general population. Finally, the cost of ineffective prohibition law enforcement is huge. On the other hand, the social benefits of harm reductions are clearly cost-effective. And here let me deliberately cite a few examples from the Eastern European region, which is so late in bringing harm reduction to scale. The $5 million that the Republic of Georgia spends annually on incarceration of drug offenders could cover, according to the Eurasian Harm Network, OST for 1,200 patients a year, a one-year enrollment of over 6,000 patients in a needle and syringe exchange treatment program, and psychosocial support for 20,000 people. In Kyrgyzstan, OST programs cost less than $1.4 per patient per day, yet the coverage with OST is less than 4% of the estimated 25 or over 1,000 people who inject drugs. By comparison, in Ukraine, a country that has done more than most in the region, close to 7,000 patients are now enrolled in OST programs, and a recent assessment of the social benefits of the programs has shown that some 30% of the clients have become legally employed. More than 60% have restored family relations. Participation in drug trafficking decreased sevenfold, and rates of other crimes about fourfold. So, dear colleagues and ladies and gentlemen, current approaches to controlling the drug problem in many parts of the world have failed. Drug supplies and violence are increasing. Community health and safety are worsening. The war on drugs is still driving the HIV/AIDS epidemic in many countries of the world. And as the Global Commission emphasizes in its recent report, fear of arrest drives people who use drugs underground, away from HIV services and into high-risk environments. Restrictions on provision of sterile syringes results in increased syringe sharing. Prohibition or restrictions on opioid substitute therapy results in untreated addiction and avoidable high-risk behavior. Lack of prevention measures in prisons leads to HIV outbreaks among incarcerated drug users. Vast amounts of precious public funds are wasted on harmful and ineffective law enforcement efforts instead of proven HIV prevention and treatment strategies. It's no longer sustainable or credible to pretend that the current reliance on drug law enforcement is effective. People struggling with drug abuse or addiction may harm themselves and their families or communities, but criminalization and social marginalization will not help them. One cannot impose health or solve drug-related problems through a war on vulnerable people. So policymakers today face a clear and compelling choice. Either they condemn countless more young people who use drugs to lives of destitution, incarceration, and disease, or they scale up harm reduction and related public health programs urgently at the same time as they tackle the economic and social problems that are the root causes of drug abuse. We can draw hope from the fact that in some countries the debate has now been opened. Latin America is now talking about drugs like never before. Argentina, Brazil, Colombia, Ecuador, Mexico, and Uruguay have recently joined a number of Western European countries in passing laws decriminalization drug possession for personal consumption. We need to strongly encourage and support these countries, as well as others that have traditionally employed an aggressive law enforcement approach to drug control, but who are now moving, often cautiously though, to a public health approach. Here I mention examples of China, Ukraine, Belarus, Kyrgyzstan, Malaysia, who are beginning to appreciate the power of the evidence and the danger of rigid ideology. So let us also continue to strongly support the many remarkable civil society groups in countries around the world, and particularly in the Eastern European and Central Asian region, who are doing so much, often without adequate resources and in a hostile environments, to advance this cause. To conclude, dear colleagues, ladies and gentlemen, let me say, if we are to stand any chance of turning the tide, of reaching our global target to reduce HIV transmission among people who inject drugs by 50% in the next 3 years, as committed by the UN General Assembly last year, we need, as an international community, to further open up the debate and fundamentally change our ways of thinking. We need, above all, to ensure that human rights are at the forefront of everything we do. Since the 1948 Universal Declaration on Human Rights and other charters have enshrined some fundamental rights: the right to health and decent care, the right to freedom from discrimination, the rights to equality before the law, to privacy, to work, to education, the right to share in the advances of science. These are universal rights. So as we embark on this day of discussion, let us remember that they are also the drug users' rights, and that we cannot win the fight against HIV without also winning the fight for these rights as well. Thank you very much.